We're recording this show from Kuala Lumpur, and my guest today is Dr. Fariq. Selamat petang, Dr. Fariq.
Selamat petang, terima kasih, Lucas.
Thanks for being on the show. So, first question will be a little bit about yourself. Tell me, how did you get into this specialty, and why is pulmonary embolism so important to talk about in Malaysia?
Thank you. So I'm working in Assumpta Hospital. I've been there for almost 2 years. Prior to that, I was doing my radiology service and interventional radiology training as well in the local university, National University of Malaysia. So what got me into intervention is definitely getting your hands dirty. I think there's an element of you that, just wants to do something with your hands, and that's where it took off.
Can you walk us through your initial diagnostic approach when PE is suspected in a patient?
So usually patients will present to the emergency department having some form of difficulty in breathing.
Yeah.
So after that, when they assess if it's not infective of origin, it's sudden, or it happens after a certain event, for example, you came back from a long haul flight, then your clinical suspicion of PE kicks in. And that's when you investigate the patient for PE. Saturation also plays an important role, where a patient comes in with not optimal saturation of oxygen within the blood, and that's when you should suspect PE.
What about D-dimer testing?
D-dimer testing takes time.
Okay.
Yeah. And if you're in a clinical setting where you don't have to wait, and you also need to take into consideration patients' lives, if you are already there, you should just go in with or without your D-dimer. Yeah. And more often than not, we go in without the D-dimer, and we do get the results that we want. We also have patients with positive D-dimers and negative findings.
Yeah.
Yeah.
First of all, clinically, your goal is patient safety and patient survival. What would you say are the key indicators when PE is likely to be massive or submassive?
Well, the key indicators for massive PE is when they come in, when they really run out of breath, and their saturation is really low, it's below 90%. And then you would definitely suspect PE. Hemodynamics also plays an important part, where they go tachycardic with hypotension as well, and that's massive PE, and inevitable vascular compromise might be an issue. Yeah.
So how does imaging, especially CTPA and echocardiography, factor into your decision-making process?
So CTPA factors in a big role in my imaging diagnosis and my management process. Based on the CTPA alone, we know whether it's a massive PE, submassive PE, unilateral PE, or bilateral PE. And based on all those factors, we can decide what treatment options should we offer the patient or the patient's family to quickly resolve this issue.
When do you bring in cardiologists?
We definitely need the cardiologist on board from the get-go. Reason being, if it's going to affect the heart, the person who deals with the heart should be there as well. Yeah. As radiologists or interventional radiologists, we never take a patient under our direct care. It's always to collaborate with others. So we go in hand.
When does the collaboration start, and how does it start?
If it's an example where a patient comes in under a general physician or a general surgeon for another issue, and PE is diagnosed after, definitely the imaging will be the first to be called in, where you get the image of a pulmonary embolism. And after that, you need to call in the cardiologist to support the case, because if anything were to happen, you need someone who is in the field of cardiology to be co-managing PE with you.
Yeah. I think that's also a really important aspect of managing PE. It's that collaboration between the teams, right? Can you speak a little bit to that?
In terms of collaboration, it's just that the cardiologist needs to know what you can do, because we already know that the cardiologist has to be responsible for the patient's well-being management, and even after you're done with your procedures, it's still the cardiologist's responsibility to relate to the patient, relate to the patient's family, whether your outcome is positive or negative. So when you're discussing with the cardiologist, you need to tell him the probability of success, the probability of failure, or the probability of a patient dying on table as well while doing your procedure. So all those things needs to be discussed, understood between both parties, and then we decide to proceed with thrombolysis or thrombectomy.
So the PERT
team,
the PERT team.
Pulmonary Embolism Response Team.
Is that being practiced in Malaysia? Is that
Yeah, it is being started in the university level, started in the bigger hospitals where you have teams who are on call 24 hours, where you have medical officers, you have house officers, you have specialists around the clock. 24/7. Whereas if you're in the private sector, manpower would be an issue. You might not be able to be on your toes 24 hours. So if there's someone else who made the diagnosis of pulmonary embolism, they can always pick up the phone and get you involved as well. So that will be not as efficient as a per team, but the next best thing.
It's a start, right? Are there common diagnostic pitfalls or delays that you see, particularly in high risk or atypical presentations?
So we do see some patients coming in with some respiratory symptoms, but probably we made the diagnosis a day later when the clinical suspicion for pulmonary embolism was not there, especially in the elderly patients. But they just come in and probably the symptoms that they present with or the history that they provided was not suggestive of PE, and then people would think of infection first. Definitely we won't do a CTPA for every patient that comes in with shortness of breath.
So how do you typically stratify patients for treatment? Anticoagulation only versus more aggressive intervention?
So to stratify patients for treatment, we definitely need to have our imaging done. We need to have our clinical assessments. And then based on those results, we will have our guidelines on how do you want to treat the patient, whether it's a low risk, intermediate risk, or whether they are high risk patients based on factors such as age, biochemical markers, presentation, saturation. So you do have low risk patients where you just use anticoagulants only, which is very safe according to guidelines. And you have intermediate and higher risk patients where you need to be a bit more aggressive, or do you need to pull back and be less aggressive? So these days we have thrombolysis as an option, ultrasonic thrombolysis. We have mechanical thrombectomy where we actually pull out the clots. So these are the options that we have for intermediate and high-risk cases as well.
And here in Malaysia, you follow Malaysian guidelines, or these are international guidelines, just out of interest?
Most of the time, our guidelines are based off international guidelines.
Okay.
Yeah, so at least I think there's a consensus in the cardiology guidelines, international, I think American Association of Cardiology. So a lot of people follows that. If you Google, that's the first thing that's going to come out as well. So most people will go to the most common ones where it's most discussed, most practiced.
Next question. For submassive and massive PE, what treatment options are currently considered standard of care in Malaysia?
For submassive and massive PE, the standard of care would definitely be intervention. I believe that's what we practice, that's what we talk in conferences, seminars, fast diagnosis, fast treatment. When you get clots which are still fresh, it's easier to manage. When the clots are hardened and you decide to do a delayed treatment for thrombolysis, a delayed treatment of thrombectomy, your results might not be as good as you hope them to be. Yeah. So these days I practice a lot of ultrasonic thrombolysis, and I do get a lot of submassive PEs actually, rather than massive PEs, and with very good outcome, very good results. For massive PEs, you're at a race against time. For an ultrasonic thrombolysis, it has a short period of action within 2 to 4 hours for you to see good clinical reversal of patients' presenting symptoms. In massive PE, you might not have the luxury of waiting 2 to 4 hours for things to break up and blood to flow. So maybe an initial thrombectomy followed by ultrasonic thrombolysis if, financially it can be supported, because using 2 devices, definitely the bill is going to go up.
What patient profiles prompt you to move beyond anticoagulation to consider catheter-based therapies?
All right. So in the patient's profiles, for example, we have young patients, fit, able patients coming in with breathing issues from pulmonary embolism. And if you were to use anticoagulants, it's not wrong, but reversing their symptoms as soon as possible would be definitely better clinical outcome, shorter clinical stay, and less risk of long-term complications from pulmonary embolism.
With ultrasound-assisted thrombolysis, is then anticoagulation not required for the rest of your life?
All right. So long-term anticoagulation, if you have an acute PE, which is not provoked from other cardiac symptoms for other cardiac failures, where you don't need long-term warfarin or long-term anticoagulants, When you treat it with catheter-based options, by removing the clots earlier, you actually clear it up. And if you, after catheter-based intervention, and you continue for a short term of about 4 to 5 days, high-dose anticoagulant therapy, subcutaneous, intravenous, then your results will be much better because it clears it all up. And therefore, after you discharge the patient, you'd probably go on a light dose of anticoagulants for another month or two, and you're off it.
It's incredible.
Just to cover up for prophylaxis if there's any microclots that you might have missed.
Yeah.
And that's it.
Can you describe how ultrasound-assisted thrombolysis works and what distinguishes it from standard catheter-based thrombolysis?
So ultrasonic thrombolysis, how does it work? It actually works a bit more different from catheter-directed thrombectomy, where you insert a larger bore catheter to pull out as many clots as you can. It might fit or might not fit the entire lumen of the where the clot is. If you get a catheter which is a smaller lumen, you might not get the entire clot out. So it's partially pulling it up one by one. Whereas if you were to use an ultrasonic, not only that you would fit through all the way to the distal vessels, which are smaller, where your aspiration catheters cannot go through, you also, throughout the entire length of these wires and catheters, you have ultrasonic waves breaking up the clots. You also have your anticoagulant working continuously to break the clots down. So you do see a very good, a more extensive, a more distal approach of thrombolysis achieved in 2 to 4 hours. So of course, when you have massive PE, this might not be the best way, and probably a synergistic mechanical thrombectomy first for the pulmonary trunk, and then you go in with your bilateral ultrasonic. That will be better.
And the distal part that you were speaking about, this is really something new in terms of research, right?
So the distal vessels, as the vessels go more distally, they are smaller in lumen. So our aspiration catheters, the main aim for catheters to aspirate, they want to aspirate as much clot as quick as possible. So they're built bigger. So they're built in a bigger lumen diameter so that they can suck out more faster. And so when you get the big ones out, the smaller ones at the sides and peripheral parts of the pulmonary arteries, those are the ones that don't get sucked up. Or you can't just go in because you might damage the vessel by forcing a larger lumen in. So that's when ultrasonic catheters play a very big role in breaking down the clots distally and thrombolizing them at the same time. And that's when you have very good results overnight.
Sounds like it's important to have in your toolbox.
Yes, definitely.
Follow-up question then, what clinical indications most strongly support the use of ultrasound-assisted thrombolysis over other interventional options?
So back to where we described, we had guidelines on low risk, intermediate risk, and high risk.
Yeah.
Definitely for you to choose ultrasound-assisted thrombolysis, intermediate risk patients, that would be the best options for them, because not only that you get to where you need the catheter to be, conventionally when you do mechanical aspiration, you also encounter blood loss. So ongoing blood loss is not favorable for distal clots. You might not be able to get it, but you'll be pulling out blood which is needed for circulation, for oxygenation. So you don't want to do that. So definitely intermediate risk patients would be more optimal to go through ultrasonic thrombolysis, yeah.
Let's keep on digging. In terms of procedural workflow, how long does a typical ultrasound-assisted thrombolytic treatment take? And how do patients tolerate it?
So in terms of workflow, we have two main parts where we do ultrasonic thrombolysis procedures. One is in the lungs for pulmonary embolism, and the other is for deep venous thrombosis in the lower limbs. We can do it as quick as 30 minutes for the lower limbs, and maybe 45 minutes or less for bilateral pulmonary embolisms. It's actually that fast, and within 2 hours, 3 hours, maybe 4 hours, you see improvement of patients' clinical vital signs. SpO2 improves, tachycardia reduces, blood pressure picks up. So you definitely see these things happening in real time.
And how long does the patient stay with you throughout the procedure?
So with me throughout the procedure, less than an hour, and then they're back to the ICU. We monitor them for the first 24 hours very intensively because we've given them alteplase, which is a very strong anticoagulant, RTPA. So what it does is a lot of people are afraid to use it because it might cause intracranial hemorrhage when you give it at a high dose. But when you use it in ultrasonic procedures, it's suboptimal dose. Why is it suboptimal? Because we don't need a systemic flow. It's localized right at the clot, right where it needs to be, and within a few hours it metabolizes, and that's it. You don't have to worry about it. The observation of the patient in the ICU is just to make sure he or she doesn't bleed out.
It's a very targeted approach, and that's why it's so effective.
For my deep venous thrombosis patients, my record is patient arrive, and within 5 days they walk home.
That's incredible.
From a swollen limb where they are unable to move or bend the legs, and they walk out in 5 days.
Yeah.
And patients who opt not to have it, they come back after 2 months still with clots within the legs, and those are chronic clots.
Yeah.
So it's off label, off the books to even try and thrombolize or aspirate them.
Yeah. So what do we know about the safety profile of ultrasound-assisted thrombolysis, particularly regarding bleeding risks?
Yeah. So in terms of the safety profile, like I said, we use alteplase, urokinase, heparin. All these at high doses or prolonged usage will definitely risk patients to have hemorrhage.
Yeah.
Not only that you cure the clot, but you might make the blood too diluted where it starts breaking out. And more often than not, they develop intracranial hemorrhage. Yeah. And that's why you don't see the bleeding. And these are things that you need to be really, really careful about. Of course, there are blood investigations that you can take. You can take the fibrinogen factor, and then you can just check it out, whether it's within the safe profile or whether it's in a lower profile, and that's when you have to stop it. But doing this takes time. Every blood investigation might take time. So maybe have a guideline of how long that you're going to use your ultrasonic catheter with the thrombolysis as well. So these days, there are some guidelines, but it's not concrete yet. So a lot of people might taper it accordingly based on the size of the patient or based on how big the clot was.
So let's keep on going. How quickly do patients show clinical improvement post-ultrasound-assisted thrombolysis, and what metrics do you track to assess success?
For me to see clinical improvement of patients, especially in pulmonary embolism, because everything's inside, there's nothing you can assess to see whether the clots are there. Clinically, we have seen improvement of vital signs within 2 to 4 hours. Yeah. And so far, all my patients within 2 to 4 hours, there is vital signs improvement. They get the wind of oxygen, the tachypnea resolves. But for DVTs, because there is swelling, you must understand that the swelling, it also goes into the subcutaneous layers as well. So there is subcutaneous edema affected. If you're going to see it within the first 2 hours, the subcutaneous edema is not going to go anywhere because the veins are congested. Yeah. The fluid is being lost to the third space, so it's going to take some time to reabsorb. From my experience again, within the third day, you do see tissue edema reducing. And for the lower limb, it's easier because you can actually use an ultrasound, put a probe there. Yeah. So within 24 hours, within 48 hours, you do see a resolution about 80 to 90% of the clots using ultrasonic thrombolysis procedures.
And when would you follow up, especially with a CTPA?
Preferably within 24 hours, but let's not expose the patient to too much radiation, too much contrast. Probably if you do see good clinical improvement, maybe in the next 3 to 5 days, just to reassess. And we did that once or twice. And we do see a 70 to 75% reduction of clots by the 5th day. So I believe that speaks for itself.
Next question then is about resources and about personnel. How does ultrasound-assisted thrombolysis compare to more invasive procedures?
More invasive procedures, you'll definitely more hands, more experienced hands to assist you. When you have ultrasonic procedures, you don't need as many workforce, and it's easier to set up. It's just an infusion pump, catheter. Once you're in. Whereas if you were to do it in a thrombectomy where you need someone else measuring the blood clots, seeing how much blood is lost, a lot more factors to take into account.
What about time?
Time, you need to go in and out when you do mechanical thrombectomy, and that takes a lot of time, multiple passes, multiple entries. Whereas thrombolysis just goes in. Once you're in, you don't have to worry about it.
You mentioned also the reduced blood loss.
Reduced blood loss, yeah, especially reduced blood loss, because the biggest fear when you're trying to save someone, you take out what's needed to keep them alive.
And then obviously all of these factors, they work towards, or they go towards also a lower ICU burden, essentially, which is beneficial to the facilities. So, to slowly come to the end, looking forward, how do you see ultrasound-assisted thrombolysis evolving in pulmonary embolism management, and what barriers remain to broader adoption?
Moving forward, thinking of ultrasonic procedures, you must always understand that the technology sometimes speaks for itself. But the difficult part for us to prove these days is that when people are so used to seeing mechanical thrombectomy, I've taken out this much clot from you, and your ultrasonic doesn't take out anything.
Yeah.
How do you know it's there?
Yeah.
How do you know it's reduced?
Can you prove it?
Yeah. So from my experience, my initial parts when I'm doing this kind of cases, the clinicians will look at me and say, "Are you sure it's done? Are you sure it's not there?" And there is a curve, there is a bit of a hill to climb to get them, because they would be the people that will be sending you the cases, trusting you with their patients. And you really need to prove to them and show to them that this works.
How do you prove it to them?
Patients need to survive.
Yeah.
Definitely need to survive and recover and get discharged and see the before and after images. So pulmonary embolism is going to be a lot harder to keep scanning them, radiating them. Whereas ultrasound, here you go. Vessels here, vessels gone.
Yeah. What are your thoughts on the barrier of device cost versus the benefit?
I think the barrier of device cost definitely takes people back. By opening a number, the first thing that they're going to think is that I've never heard of this, and you're telling me this is the price. So that's a challenge on its own. That's human communication. It comes down to the grassroots level of you being able to communicate to the patient, for the patient to trust you. Yeah. I can share with you this first experience of a venous thrombosis that we did. Yeah. She was not a local lady. She was from the UK. And we were telling her we're going to do this, and her husband was there. It's like, I've never heard of such things. Am I an experiment? And that's when you really need to steer things, with your knowledge, your confidence, and let them believe that this is going to work and this is the best option for them.
Did you have a good outcome with that case?
It was a very good outcome.
Fantastic. That's the only proof that you need. So do you feel there are any Malaysia-specific challenges that influence the use of ultrasound-assisted thrombolysis?
In Malaysia, I feel that the most important thing is clinical education. Our outreach is to the doctors rather than to the patients. And when the doctors understand that these procedures are available, these procedures are accessible to them and their patients, and definitely probably that's when we would definitely get a better response.
Yeah.
So probably an outreach program, or probably doing CMEs, getting them on board to what's new and what's available.
I mean, we talked about quite a lot here, of course, in this, but what would be your message to someone that is considering a referral?
I think be open for discussion. That would be the most important. Yeah. Just pop the question, can it be done? Can you try, or should we? Probably those are the three things that probably if you put it into a conversation, then the best outcome comes to the patient.
There's a discussion, discourse, conversation is the basis for progress. Thank you very much for shedding light on these crucial aspects of PE care, in particular on ultrasound-assisted thrombolysis, and how that technology can improve both outcomes and the quality of life in patients. So, terima kasih, Dr. Fariq.
Thank you so much, Lucas.
It's been a pleasure to have you.
Thank you for listening. Please don't forget to subscribe to the Getz Healthcare Malaysia Conversations podcast for more informative episodes like this.